Oh, maybe I don't have enough structure for it, which is, that's what it is.
Crazy busy.
Okay, so welcome to everyone who's joining us online, and we are doing sweat gland tumors today, and Shane's going to start us out.
So it would be an acrospiroma bruise that looks kind of like a clonal seb but has duct.
So something that looks like a clonal intraepidermal seb but has ducts, and so that would be hydranthoma simplex. Very good. And you can say it either way. Hydranthoma, hydranthoma, it's tomato, tomato. The cells of an acrospiroma have ample cytoplasm, so they are pink tumors, whereas a lot of the others are just nuclei only. The ones that differentiate towards secretory coilin are blue tumors. So this is one of the red tumors because it has cytoplasm. An acrospiroma. The cells are the same size as the cells of a seborrheic keratosis, because these differentiate towards the eccrine duct, and seborrheic keratoses differentiate towards the cuff of cells immediately surrounding the eccrine duct. So, you know, they're very similar cell populations, closely related. Okay. You're going to have to...
I'm Paige.
Paige, thank you. You're going to have to accept my apology in advance. So Paige, what do you see?
So it looks like a dermal lesion. It kind of has the paisley tie pattern, potentially.
There's certainly some islands, and are they sitting in dermis, or are they surrounded by some other kind of material?
I guess they're more so surrounded by another material.
So, Shane, could you come up with a really poetic description of what you're seeing? Exactly. So, blue islands floating in a sea of snot. Pure poetry, right?
Mucinous carcinoma?
Mucinous carcinoma, correct. So, mucinous carcinoma of skin looks just like mucinous carcinoma of breast or mucinous carcinoma of GI tract. They look very similar. There's some immunostaining differences for the GI ones. They're CDX2, like a GI cancer, unless they're rectal in origin. But the breast and sweat gland derived ones are pretty much identical in staining because breast is a modified sweat gland. So the patients definitely all need a workup. Okay, Rachel.
All right, now this looks a little more paisley tie-ish. Got like a
And
kind of pink sclerotic.
does everyone
stroma.
notice I wore a version of a paisley tie today?
We need to get some tadpole-shaped ducts.
Yes, exactly. So they're kind of tadpole or paisley. So you think this is a syringoma?
I don't really see any like horn cysts or a lot of ducts.
And what's that structure?
It's a nerve.
Yeah, nerve.
So we've got some perineural invasion.
So
which makes
even the
this-
tiny
which
little
makes this a bad thing.
teeny weeny nerves are showing evidence of perineural invasion. So this is something that looks kind of like the syringoma from hell.
I want to call this maybe a microcystic adnexal carcinoma.
Yeah, a MAC. And what's this variant of MAC called? It looks like a syringoma that just keeps on going with perineural invasion.
I'm not sure.
So that's the sclerosing sweat duct carcinoma, which is, MAC is called microcystic adnexal because it differentiates pilar and sweat. It goes both ways.
And this doesn't have
And
a
this
pilar.
one is kind of a monophasic MAC. So a purely sweaty MAC is the sclerosing sweat duct carcinoma. So it's a type of microcystic adnexal carcinoma. Like other MACs, it can have paisley tie. Unlike other MACs, it doesn't have blue islands. It only has pink islands that are kind of tadpole-like. but they show perineural invasion, they have deep extension, and are associated often with nodular lymphoid aggregates. Okay. So sclerosing sweat duct carcinoma, some people just refer to it as a sweaty MAC. So microcystic adnexal carcinoma, where do they tend to occur? 99%?
I don't remember.
Right around your mouth, right where the sauce from a Big Mac gets on your face. Right.
Whatever it takes to remember.
Exactly. So, it makes it easy that it's where the Big Mac sauce gets on you is where you get Macs. And so when they are biphasic with both pilar and sweat duct differentiation, we just call it microcystic adnexal. When it's pure sweaty sweat duct-like, we call it sclerosing sweat duct carcinoma. And when they're very large, you call it Big Mac. That could be on an exam. Okay. Okay, Christina.
Hydrocystoma.
Yeah, hydrocystoma, a simple sweat duct cyst, cuboidal epithelium, usually in a double layer, and it can be stretched out to the point where it's kind of flatter just because of the stretch. They used to talk about eccrine and apocrine types. Probably none of them come from mature glands. Instead, they come from primordial stem cells, a lot of them, and most of those go down an apocrine path. In fact, most sweat tumors go down an apocrine path because apocrine glands are the primordial gland. Only primates have eccrine glands. Anything, we are very primate-centric in the way we classify things. So we would say anything below a primate in the phylogenetic chain has only apocrine glands. Others might say other species parallel to the primates have apocrine glands, and we're a quirky offshoot that has eccrine glands, but it's only primates that have eccrine. So most tumors, not surprisingly, go towards the more primitive gland.
This looks like a mixed tumor to me.
Okay, why does it look like a mixed tumor?
Well, you have a lot of mixes of different things, including what looks like a cartilaginous background, stroma. I think this is the alveolar type, the branching alveolar type.
So that is beautifully done. So it's called a mixed tumor because it has both mesenchymal elements and epithelial elements. It is also called chondroid syringoma. Either name is fine. This is the more common type, which is the branching alveolar type. Branching and alveolar ducts that surround areas of stroma, often with a blue mixoid hue. So kind of a gray-blue mixoid hue, and there are anastomosing strands of epithelium surrounding areas of stroma. Kind of the opposite of a mucinous carcinoma, where it's the stroma, it's the mucins surrounding the little blue islands. Here it is definitely anastomosing strands that surround and trap areas of myxoid stroma. And they're essentially the same as pleomorphic adenoma of the salivary gland. Is essentially the same tumor. It's just one is salivary origin, one is cutaneous duct origin. Okay. So, David, what do you think?
All right. See lots of islands of blue cells.
Islands of blue cells.
Followed by some red basement membrane. Looks like a cylindroma.
Okay. Do cylindromas have any pink cytoplasm?
No. Okay, so it's more of a poroid.
So more of a poroid neoplasm, but what do you think about the nuclear size and the nuclear cytoplasmic ratio?
It's big. So
It's big and awfully cellular.
Yeah.
So what would you call a big, awfully cellular poroid neoplasm?
is it a malignant?
Malignant poroma, malignant acrospiroma, porocarcinoma. There are about 20 names for the same tumor. Any of those names is fine. Like a lot of other malignancies in skin, the first thing that you'll notice is that it has too many nuclei. Right? Your nuclear cytoplasmic ratio is not that of normal tissue. Here you have pleomorphism of nuclei. The nuclei are big. The ratio of nuclei to cytoplasm is too many nuclei. Yet you still have areas of duct differentiation, and you have areas of sweat. So from scan, it's a bluish, sweaty tumor with ducts. It's bluish not because it has no cytoplasm, but because it has some cytoplasm but too many nuclei. And that puts you in a porocarcinoma, malignant acrospiroma type of differential. Very good. Okay. So, Blake, what do you think?
I want to say in the acrospiroma category.
In the acrospiroma. So in this chapter, if you're pink with ducts, you're going to be an acrospiroma. And pretty much anywhere in Dermpath, if you're pink with ducts, you're going to be an acrospiroma. If you're blue with ducts, if you remember from last week, you're going to be a sebaceous neoplasm. So blue with red circular ducts is going to be sebaceous tumor. Pink with ducts is going to be an acrospiroma group of neoplasm. And this acrospiroma, is it uniformly pink, or do you have areas that are pink and areas that are densely cellular bluish?
Second one.
Shockingly, it's the second one. And so that is often sign of a poroma going bad. So an acrospiroma. So names for the acrospiromas: poroma, hydradenoma simplex, dermal duct tumor of Winkelmann, nodular hydradenoma, clear cell hydradenoma, solid and cystic poroma, poroid adenoma. You know, half the book is just names for this one tumor. You know, variants of the one tumor. So just recognize them all as synonyms. And if they have a nuclear cytoplasmic ratio similar to normal sweat ducts, they're benign. And when they are just solidly packed with nuclei, they're probably malignant. Okay, Rob.
So I'm thinking mixed tumor.
Okay, why mixed tumor?
Because it looks like there's a lot of there's mesenchymal areas and then epithelial areas as well.
Yeah, and in fact you see chondrocytes in areas. You know, there's
Right.
definitely cartilage here. And you have a branching and alveolar pattern. And in some areas you have small tubules. So this is a hybrid, small tubular type. So it's a mixed tumor. You are correct. So parts of it are branching and alveolar, parts of it are small tubular types. So this is definitely a mixed tumor. But you have the stromal, chondroid, myxoid elements and the branching alveolar and small tubular glandular elements, and shockingly, there's apocrine snouting in some areas because virtually every tumor, if you look, if it's a sweat gland tumor, can show apocrine differentiation.
So we did learn last time that actually the screen still projects and is recorded.
Oh, really?
Yeah.
Oh,
Even though-
good.
even
So
though it
even
looks
though
like it-
we're locked down, they are not.
So we probably can just leave it, but
Okay. Well, but I need to see where I'm pointing
Oh,
for
yes,
those
yeah.
on screen and stuff. So, thank you. Okay.
yes as well.
Caleb,
So we're in a Paisley tie differential here.
a Paisley tie differential.
Looks pretty small and well circumscribed. Maybe some clear cell change at the clear cell syringoma.
So there's definite clear cell change where they're glycogenated. And so they are fat tadpoles, right? Because they're glycogenated in clear cells. And clear cell syringoma has some association with what underlying condition?
Diabetes.
Diabetes. Basically, there's so much sugar around that it's easy for them to get glycogenated, right? Not everyone with clear cell syringoma has diabetes, but you certainly have to look. So this is a small pea-sized, actually they're like two peas side by side here, two peas in a pod. So you got two little peas of sweat ducts in a sclerotic stroma. All of the Paisley tie neoplasms have a sclerotic stroma. So in this case, you can see that it's a little BB-like thing, so you know it's a syringoma. But if you only have the top of it shaved off, then you need clinical pathologic correlation. So if you have just the top of a Paisley tie tumor, and I'm telling you that I am an Asian woman or a kid with Downs, and I have tiny little papules on my lower eyelids, what do you think I have?
Syringoma.
Syringoma, but I lied. I'm actually a young woman with a pale donut-shaped lesion on my cheek with a central depression.
And I think you would have a desmoplastic
A
trichoepithelioma.
desmoplastic trichoepithelioma, but I lied. I'm actually a 55-year-old man with an expanding plaque on my upper lip.
I think you had a microcystic
Microcystic adnexal carcinoma, but I lied. I'm actually an 85-year-old man with a scar-like lesion on my forehead.
That you have Mohs in your future.
I have most of my future because that's probably a more uniform BCC. So what have we learned?
There's a broad differential for Paisley tie, and it's
Well,
based on clinical history.
That's
a lot of
one,
time.
and the more important that I am a liar.
Oh, well, yeah.
I am a liar, and the Paisley tie, if you just have the superficial portion, you need to know what the clinical was to make any sense of what the patient has. Okay. So, Dan, you want to jump in?
Sure. This reminds you of the tubular apocrine adenoma.
Yeah, it looks kind of like a tubular apocrine adenoma. We're actually, though, in the axilla, and so those are just normal apocrine glands. And then immediately adjacent to that, what's happened? So you have normal apocrine glands, and then growing out of them, you have these highly abnormal apocrine glands, right? They have a high nuclear cytoplasmic ratio in areas. Let's try to get that in focus. In areas you have nuclear molding, just like you get in breast cancer. So what do you think is going on here?
I think we need some stain.
Yeah, but there are two possibilities. One is it's a primary apocrine carcinoma,
Right.
which can happen, which is what this turned out to be. The other is the tail of the breast goes up into the axilla. So, this is either carcinoma of the axillary tail of the breast tissue, or it's a primary apocrine carcinoma. it almost doesn't matter because breast carcinoma is an apocrine carcinoma. So, whether it's primary in the apocrine glands or whether it's primary breast, the behavior is pretty similar.
Do stains help at all in this?
Not really, because breast is apocrine. So yeah, they stain pretty much the same. Okay, Katie, what do you see here?
So, a kind of branching alveolar-like gland. It's pretty well circumscribed, sort of a pseudocapsule. As far as location, it doesn't look acral. I think it could just be an HPAP if it was from the right location.
Yeah, so if this were a vulvar tumor, because it is configured like a maze you could hide in, it's an HPAP, whereas the SPAP always connects to the surface so you can slide into the SPAP. So you hide in the HPAP, you slide into the SPAP, right? And both are apocrine tumors. Now, you alluded to the fact that you didn't see features of acral skin. Why would that be important?
I can remember asking you that kind of maze-like proliferation on acral skin. You worry about the aggressive digital papillary carcinoma.
Yeah, exactly. So you are absolutely correct. So something that looks kind of like an ugly solid HPAP on a digit is going to behave as metastasizing adenocarcinoma. So aggressive digital papillary adenocarcinoma. They used to divide them into digital adenomas and digital adenocarcinomas. And then Wayne Duke did a follow-up of all of the adenomas and what happened to the patients, and a significant number of them metastasized. So, they eliminated the category of adenoma, and they're all considered adenocarcinoma. So here, you got a big vessel at the bottom, and then you have lots of sweat glands. In fact, lots of sweat glands. Is it normal to have sweat glands up around your hair follicles here in the hydermis? No. So you got lots and lots of sweat glands, and they're all surrounded by blood vessels. So it looks almost like an arteriovenous malformation, but a sweaty arteriovenous malformation. So what would you call a sweaty arteriovenous malformation?
Eccrine angiomatous hamartoma.
Eccrine angiomatous hamartoma. And so they are bluish, cyanotic, tender nodules in Amish people. In fact, I'm not sure they've ever been seen outside of the Amish population. So, in central Pennsylvania, this is not an uncommon tumor. Same in parts of Ohio and Indiana and anywhere where there's good cheese and dairy farms. But you get away from where you have an Amish population and you just don't tend to see the tumor. So, it's some kind of founder effect that it's in that population.
It's in the cheese.
Okay.
So,
Nicole, what do you think?
You have islands of blue cells. It looks like maybe there's too many cells.
Islands of
They
blue
also-
cells may be too many.
They connect to the surface.
They connect to the surface.
I would like to go down and make sure that they don't look atypical and scary,
Okay.
but I'm kind of in the...
Tell me about what's going on here.
Some sclerotic hyalinized stroma.
Sclerotic hyalinized stroma that looks almost like osteoid and surrounds blood vessels. And that kind of stroma, osteoid-like stroma, is characteristic of what group of tumors?
The or the acrosporoma.
Yeah, acrospiroma group. It's so characteristic that it's called poromostroma. So poromostroma is that red It's a million wraps of basement membrane zone around the vessels, causing this red osteoid-like stroma with tiny little blood vessels embedded in it. It is absolutely characteristic to the poroma group, but as you pointed out, poromas tend to be red. This one is bluish because there's so many nuclei, so this is probably poroma gone bad or porocarcinoma, malignant acrospiroma.
This one looks like sort of mixed.
So some portions of it maybe suggest a mixed tumor. Does it appear to be well circumscribed, or does it appear to be invasive?
Maybe invasive.
Maybe more invasive. And has some large islands, small islands. It's certainly laying down a tumor stroma, which is partially myxoid. And when you look at the islands a little closer, do they have a normal nuclear cytoplasmic ratio
No.
like normal glandular tissue, or do they have a high nuclear cytoplasmic ratio, nuclear molding, hyperchromasia, pleomorphism, and mitoses?
All of those.
So it would be the second choice. And so do you think this is malignant or benign?
Malignant.
And so this could be a malignant mixed tumor. Could be, certainly some kind of sweat duct adnexal malignant tumor. So malignant acrospiroma, malignant mixed tumor. Doesn't matter that much because the behavior is going to be the same. They both have potential for metastasis. They're going to be locally aggressive.
This is a very superficial shave pigment in the dermis.
Okay, and so there's cells that are smaller than the surrounding cells, and they're forming pigmented little clones. So very much the size of cells in Hydranthoma simplex, and those are the same size as what other? Given that we have horn cysts here.
Like a sub-K.
Yeah, like a clonal seb, which is in the differential for Hydranthoma simplex. And then if you look a little higher, you can see not only is there pigment, but in some areas there are pigmented dendrites visible. So anyone want to chime in? What are we looking at? Melanoacanthoma, where you have dendritic melanocytes as part of the tumor. So you can have pigmented poromas. They're actually quite common, especially in darker-skinned races. You see pigmented poromas. But you remember the pigmented seb and melanoacanthoma are in your differential. And there are some of the really nice pigmented melanocytes, dendrites in the tumor.
So if you saw ducts, you would be more in the poroma?
If you were ducts, it would put you in a poroma differential, and in the absence of ducts and presence of horn cysts, then it's a seb. But the cells are the same size, and they look very, very similar. Okay, so Rachel.
Okay, so looks like I've kind of got a mixed tumor. There's some blue chondroid type stuff and pink strands.
So pink strands, and they are anastomosing and forming a net-like pattern that surrounds areas of the bluish stroma, and in other areas you got red sweat. So it's a sweaty tumor, and it's a sweaty tumor with a branching alveolar pattern, trapping mesenchymal elements and fat in the mesenchymal elements. So
it's a branching alveolar mixed tumor.
Branching alveolar mixed tumor. Very good.
So we're in our Paisley tie differential.
Okay.
From this tower, I don't see any liquid aggregates, and I see what look like to just be tadpole-like lesions. So I would guess a syringoma.
So, syringoma, if it is, oops, sorry, slightly out of focus. So, small Paisley tie, small BB-like growth with Paisley tie islands embedded in a sclerotic stroma. And if you don't know the size of the lesion, then you need to know your clinical history, just as we discussed before.
So this appears sort of jigsaw puzzle-like, like I was thinking of Cylindroma.
So jigsaw puzzle-like, so they are blue island cells that have very little cytoplasm, but they are surrounded by red basement membrane zone that separates the jigsaw puzzle pieces, and there are little droplets of basement membrane zone material within the tumor. And the tumor itself is composed of two cell types: darker gray cells at the periphery, paler gray cells towards the center, and it is not inflamed with lymphocytes. So this is a cylindroma, as you said. A spiroadenoma is the same tumor, except that it is solid growth pattern, not jigsaw puzzle, and it is inflamed with lymphocytes. Of the two, which one is spontaneously painful?
Spiroadenoma.
The one that's inflamed. Okay. David.
I'm seeing shave. Epidermis is a little thickened, and looks like there are maybe some kind of polygonal cells hanging off of it.
Okay.
However, so yeah, it's more a scanning view. I see more of this kind of system, almost like a fronds appearance, like a
So
syringo
there are
cyst adenoma.
fronds within spaces,
Yeah.
and does it connect to the surface?
Yes, it looks like it probably all would connect to the surface.
So one could conceivably slide right into it. So what is it?
So syringo cyst adenoma papilliferum.
An SPAP. Exactly, because the SPAP you can slide into, whereas the HPAP you hide in. Right? So this is an HPAP, which doesn't connect to the surface. But if you have something that looks like an HPAP on a digit, take a good look, because it's probably malignant, and those metastasize and are bad actors. So something that is HPAP-ish, but on an acral site, be careful.
Looks like dermal blue island.
Okay. Dermal blue islands. And you've got, over here you have fat.
Mixed cell. Or mixed tumor.
Yeah, so this looks like a mixed tumor, right? Even from scan, you see fat, you see a branching alveolar pattern, But then in the center here, you have a mama follicle and baby follicles hanging off of mama follicle. So what do you have?
Trichofolliculoma.
Yeah, so you've got areas that are trichofolliculoma, or at least fibrofolliculoma with, strands. I'm not sure that they're really forming hairs or full baby follicles, but something between a fibrofolliculoma or a trichofolliculoma embedded in or part of a mixed tumor. So this is another mixed tumor, right? Mm-hmm. And so what would you call this? You'd call it a BAT, benign adnexal tumor. So, some things, mixed BATs are pretty common. These things, they don't come from mature hair follicles and mature sweat glands. They come from primitive stem cells. So they can go down a pilar tract, they can go down a sweaty tract, they can go down both. So this is just BAT, benign adnexal tumor, NOS, you can say, or I would probably say benign adnexal tumor with elements of fibrofolliculoma, trichofolliculoma, mixed tumor of skin. The mixed BATs like this don't tend to be associated with any syndrome. So remember last week we were, every tumor seemed to have a syndrome associated with it. These mixed BATs and most of the sweat gland neoplasms don't have syndromes associated with them. It's more the pilar ones that do.
Let's see. I guess I would put this in the tadpole differential.
Yeah, so it's kind of a punch out of a tadpole tumor. So you want to know where it's from, how big it is.
Right.
The history is this is a 20-year-old black male with 1,000 dark brown papules on his chest and similar papules on his penis.
So eruptive syringoma.
Eruptive syringoma, which is almost exclusively young black males. They tend to come in for the penile lesions because that's what troubles them. And they're benign in behavior.
Pretty large dermal tumor. I feel like a lot of pleomorphism and hypercellularity.
Lots of mitosis, lots of visible nucleoli, irregularly shaped nucleoli with stems attaching them to the nuclear envelope, starfish-shaped nucleoli, very high nuclear cytoplasmic ratio. So you're pushing for something benign?
Yeah, that was on the tip of my tongue.
Yeah, so probably highly malignant, aggressive. This arose in a long-standing spiroadenoma. What we're looking at now is a metastasis. And malignant acrospiromas are bad enough. Malignant spiroadenomas are really bad. They have a very poor prognosis. They're very aggressive anaplastic tumors. So the malignant spiroadenomas are worse than the acrospiromas in terms of their behavior.
What sort of the acrospiroma look to it? What sort of?
So like an acrospiroma look, it's certainly a pink tumor with ducts. Blue with ducts is sebaceous. Pink with ducts is acrospiroma group. A lot of these islands are embedded within the surface epidermis. and there happen to be horn cysts. So is it a clonal seb? Probably not, given that there are ducts about every 2 inches, right?
Mm-hmm.
So, but it shows you there's a lot of overlap, and most of the time, unless the ducts really hit you in the face, it wouldn't be fair to ask you the difference between a clonal seb and an acrospiroma. You'd have to have very obvious duct formation for that to be a fair question. Okay, Katie, what do you see?
Very chondroid. It's like they're tiny little.
Yeah, so you got what looks like a chondroma, right? But you have one tiny little area of duct. So what is this?
It makes it mixed.
Yes. And this is one that we had one fellow who liked to call this a chondroid syringoma. Right, so, big chondroid and little syringomatous element in it, right? So it's just a mixed tumor, and you can have any proportion of the mesenchymal and the glandular elements, right? So this is big chondroid, little syringoma.
So, pretty well circumscribed dermal nodule. It almost looks like it connects to the epidermis, although it has largely a kind of a maze-like architecture.
Yeah, kind of HPAP-like, right? And what's down below it?
There are some ducts and lobules, and it appears to be breast tissue.
Yeah, so that is mammary-type tissue.
So nipple adenoma.
And when you look at it, you can see grossly that's sitting in the nipple, right? So this is a nipple protruding upward, and then this is within the nipple. And you look higher, you can use a P63, or here it's pretty easy to see just on H&E that you retain a nice myoepithelial layer everywhere, and the epithelium, although it forms tubules, it's not highly atypical, and so this is more likely a benign intraductal papilloma. What's the clinical name that gets applied to that?
Erosive adenomatosis.
Because often it looks erosive on the nipple, so erosive adenomatosis or benign intraductal papilloma of the nipple, same thing. And because of the differential with DCIS, ductal carcinoma in situ, my practice is not to sign these out by myself. This is one of the things that I always call in a surge path person or a path dermpath. I think should look at these with me. Although I've been looking at them for a long time, I'm pretty comfortable. I haven't been wrong in a great many years, but the stakes are high, and so we are a discipline that comes from two sides. My friends in surge path bring me inflammatory and alopecia and infectious things all the time, and I show them tumorish things that where I don't want to make a mistake, because there are no prizes for bravado, and there's a patient on the other side who's going to suffer the consequences if you're wrong. So intraductal papillomas, although I'm fairly comfortable with them, they never have my signature as the only signature on them.
In path residents, these come up a lot on test questions, because you can look at them too close and the nuclei look big and kind of atypical and this and that, and so they want you to be able to recognize that it's benign versus calling it a malignant breast tumor, because that's a huge change in treatment for that patient.
Yeah. Thank you.
Mm-hmm.
Okay, so whose turn are we?
It's me, sorry. So there are islands and ducts that almost look a little, maybe both sweaty, and I can't tell if there's pilar type of islands in there as well, but there's, I think, necrosis, which makes me nervous. It looks like it connects to the surface. We might be on acral skin, maybe. There's also some, I think, what look like infiltrative types of islands in there, or they might be blood vessels. I can't tell from this power.
Okay.
But I'm already in the nervous category.
So already in the nervous box. And so we go higher, and it is a sweat gland tumor. I'm not picking out a good myoepithelial layer in some of these islands, but parts of it look very well differentiated and ducty, like a Cyst Adenoma type of tumor. So the question is this just Cyst Adenoma with some pyknosis of nuclei and programmed cell death, or is it worse? You might look at a MIB, you might do a P63 and show that focally you do have myoepithelial layer preserved. Because again, you're between a kind of DCIS and a benign intraductal adenoma, even though this isn't nipple adenoma, it's the same question. So you can get them anywhere you have sweat glands, you can get the same differential.
I don't remember cyst adenoma in the chapter. What?
Cyst adenoma is like a hydrocystoma with an attitude. So it's just like a benign intraductal papilloma of the nipple, but anywhere else on skin.
Okay.
Sorry, and it's not in the online material either.
Maybe, I don't remember it.
Mentioned in the online. There are lots of things we added in the online only in the second edition because we had a page budget. In third edition, we got a lot more pages, so all of that will migrate into the text. So right now, it's all there, but some of it's online only right now. Okay, so how about this one, Shane?
Well, it's in the dermis, but it looks like it's brown. Pretty well demarcated, like in a paisley tie.
Yeah, so a little paisley tie, shockingly in a sclerotic stroma, and this one's a little round BB, so it's a Syringoma. Very good.
Looks like a large blue ball in the dermis.
Like a large blue ball, and the blue ball has,
That's lymphocytes.
it is peppered with jet black lymphocytes, so this one is a?
Cyst Adenoma.
Correct. Very good.
Okay, so this I've got really pretty large nodule with like pink stroma with these blue chondroidy islands in it.
Yes, you have blue chondroidy islands, and you have a branching and alveolar anastomosing pattern of ducts.
So it's a branching alveolar mixed tumor.
Yeah, and the stromal element, some of it's chondroid, some of it's fatty. So another mixed tumor. Mixed tumors have endless variety, and it's a common tumor, so for path boards, I'm sure they would be very good. They would probably test very well because endless variety of a common tumor, they don't all look just like the picture in the book. So you actually have to know what you're doing to work your way through them.
Hydrocystoma.
Yep, top of a hydrocystoma, and they're frequently shaved off, and so you just get the top.
Sort of looks like another cylindroma.
Looks kind of like another cylindroma. What color are cylindromas?
They're pinks. This is more blue.
So cylindromas are
Blue. I said it.
blue,
Sorry.
outlined by red basement membrane zone. Do you see any red basement membrane zone in this?
Not really.
Not really, but it definitely has the dark gray cells and the paler gray cells, just like a cylindroma. So, if it doesn't look like a benign cylindroma,
And a bad cylindroma.
and a bad cylindroma, so something that looks like a cylindroma but is totally lacking that basement membrane zone that's supposed to be there, is going to be a bad actor. So a malignant cylindroma. So on the pilar side, we had a lot of benign tumors with nasty syndromes associated. On the sweat gland side, you have a lot of benign tumors with no syndrome, but a much higher tendency to turn malignant. So,
let's see. So it looks like we almost have a kind of circumscribed nodule.
so do you think it's circumscribed, or do you think the cut edge still has lots of tumor?
Yeah, with that edge, yeah, just straight to the edge. I thought I saw the cuticle kind of on the edge. Looks a little bit like branching, a little like reticular.
Kind of branching, alveolar, reticulated.
I mean, you can make me think about like a malignant mixed tumor, maybe.
That's exactly what it is. It's a malignant mixed tumor. So you can see the stromal elements. You can see the glandular elements, but it's invasive. It has areas of necrosis en masse. It is hypercellular, and so it's a malignant mixed tumor. But it still keeps some of its branching alveolar architecture, so you know what it is. Okay. How about this, Blake?
Hydrocystoma.
Hydrocystoma, and in some areas
See that
it's forming tubules and things in the wall. So what would you call something that's like a hydrocystoma that has adenomatous elements?
Adenomas hydrocystoma.
Yeah, or a cyst adenoma, right? So cyst adenoma is like a hydrocystoma, but it's getting some tubules, so it's going towards an adenoma. So the ones on the nipple are very adenomatous. The ones from other sweat glands, they start with just little tubules and little papillomatous areas within the cyst, which is why it's called a cyst adenoma, because it's adenoma in a big cyst. And I think we're at the end. So that's it. The only thing I think that you didn't do that you should have done with Justin was in the chapter was adenoid cystic CA. So make sure you recognize that pattern as well. Go back and review that. I think we pretty well hit everything else in the box.
We had syringofibroadenoma. Yeah.
Oh, syringofibroadenoma of mascara. That's true. Okay, so there are two there.